Good afternoon, and welcome to the Care 360 sponsored webinar, MACRA 2018, CMS Explains the Path Ahead. My name is Colby Dix, and I will serve as your moderator and host today. We have a lot of material to cover in this hour and are very pleased to have two outstanding speakers from the Centers for Medicare and Medicaid Services with us today. Our agenda for today is on the screen for you now. We'll begin with an overview of the 2017 participation requirements, followed by coverage of the proposed changes for year 2. There will be a Q&A session directly following, and please also stay with us for a brief overview of Care 360's complete suite of healthcare IT solutions. I'd like to extend a warm welcome to our presenters today. Dr. Limene Tefera, or TEF, is a health policy advisor with a background in health and behavioral economics, decision-making, and clinical expertise in emergency medicine. With his continued studies and work as a senatorial advisor, he brings a wealth of experience to his role at CMS as a medical officer and policy advisor. Benjamin Chin is an analyst for CMS specializing in healthcare policy. His in-depth knowledge of the quality payment program and the many intricacies that follow have been in high demand as a speaker for CMS in sessions just like this one. We're very lucky to have them both with us today. I'm going to go ahead and hand this deck off to Ben, as he's going to start us off by outlining some of QPP Strategic Goals.
Great, and thanks, Colby, and good afternoon, everyone, and thank you for joining today's webinar on the Quality Payment Program for Performance Year 2017 and the Year 2 Proposed Rule. As you'll see on the slide, we have, these are QPP's 7 strategic goals, and we are proposing to achieve or work towards these goals through both the merit-based incentive payment system and the advanced alternative payment model track of the quality payment program. We do have more information on these strategic goals and how we're measuring success towards these goals on the quality payment program website at qpp.cms.gov. So I do encourage attendees on this webinar today to visit the quality payment program website to get some more information. And now I'll turn the presentation over to Dr. Tefera to run through easier access for small practices and to get into a bit of an overview of the quality payment program.
Hi there, good afternoon, everyone. This is Limene Tefera from CMS, and happy to discuss the merit-based incentive payment system and the QPP program. Let's see here. We're just going to start off with a review of how the program has been designed to minimize challenges for small practices. We'll get into this in more detail later, but the salient message is that we are cognizant of the challenges of quality measure and clinical practice improvement activity reporting and electronic health record, advancing care information reporting, and we want to make sure that all practice sizes, from single practice clinicians to large group sizes, can be successful, and there are various program changes through rulemaking that we proposed and might finalize for QPP 2017 that we think make it easier for small practices. Now on the title, the slide entitled, How Does the Merit-Based Incentive Payment System, or When Does It Officially Begin? This is a quick overview that most folks are aware of, that we are currently in the performance year. You'll see that the deadline to submit is the end of March 2018, and that relates to a spillover of claims data after the completion of the calendar year. During 2018, we'll be providing feedback to clinicians, a progress report on their performance during 2017 on the metrics that they've submitted. And once we complete the analysis of the metrics submitted for the MIPS program, the impact on their Part B payments will start in January of 2019. Who's involved in MIPS? The short answer is all physicians, physician assistants, nurse practitioners, clinical nurse specialists, and certified nurse anesthetists are participating in MIPS from the beginning, and that's called out directly in the statute. There's also statutory language to expand participating clinicians in MIPS, but for the first year, and also for the proposed rule in the second year, these will be the clinicians. It's also important to know who is not participating, and the exclusions are really determined by the amount of spend in Part B services, the amount of charges that clinicians claim. And you'll see that if a clinician has less than $30,000 a year, or if she sees fewer than 100 patients, she'll be excluded. If a clinician is a new enrollee to Medicare, for example, a resident clinician finishing mid-year will not participate during that year, but will start the following year. And the final exclusion is if a clinician is a qualified APM participant in advanced APM, and again, we'll be talking about those details a bit later, they are also excluded from the MIPS program. The salient point here is that all clinicians will be participating in MIPS unless they have an exclusion, and those exclusions are called out on this slide. How will you know if you are exempt? Fortunately, the QPP website, right on the landing homepage, has an NPI lookup tool that we encourage everybody to use to determine if they've been identified as a participant. But again, following the descriptions in the last couple of slides should give you a good sense if you'll likely be participating. Looking to making sure that the quality payment program is sensitive to the practice needs of clinicians in all different types of practices. We also want to note that for clinicians billing in rural health clinics and federally qualified health centers, that depending on the payment methodology, which is to say if all their billing goes through a special payment policy for those centers, they would not participate in the MIPS program. However, if they are billing independently their Part B services, they would still be participating in MIPS. Slide again here calls out a policy for critical access hospitals. There's a lot of text on this slide, but the best way to simplify it is this. Clinicians who claim charges in Part B will be participating in MIPS, whether they have assigned their billing to critical access hospital or not. It's important to note that the reimbursement of the critical access hospital itself will not be impacted by the score of the participating clinician. So the salient point here is the MIPS clinician, so long as they're involved in Part B claims, will be participating in MIPS, but the facility will not be impacted by their participation. Moving forward to how the program works in this first introductory year, many folks will have heard of our Pick Your Pace moniker, and that really talks about the flexibility we wanted to offer clinicians who express concern about a program that was intended and is intended to minimize the challenges of reporting in our previously existing quality reporting programs. And there I'm referring to the Physician Quality Reporting System, the Value-Based Modifier, and the EHR Meaningful Use programs. MIPS has thoughtfully combined those programs with the aim of decreasing reporting challenges and decreasing challenges of submission. But for the first year, we wanted to make it even easier. So for folks who think that they're not quite prepared to fully participate, they can essentially choose one measure, one clinical practice improvement activity, or submit the base requirements for the advancing care information to successfully avoid a negative payment adjustment. Again, one measure, one activity, or the base requirements for advancing care information would help avoid the -4% payment adjustments that's called out in the statute. Moving on to the next slide, number 10 here, you'll see that we expect that most folks will actually submit more than that minimum single measure activity requirement. Based on prior experience with the physician quality reporting system, value-based modifier, we think clinicians are comfortable and already have systems in place, either individually in their practices or through vendors, to submit more than the minimum. And you'll see that partial year reporting starts at roughly 90 days, and a full year reporting is really however much the clinicians can submit during the year, but is above 90 days. And we think many physicians will try to target partial and full year participation. Moving on to the next slide, just a review of methods of submission. Again, a lot of information on this slide, but the main emphasis here is that regardless of whether you're an individual or a group, you can submit via registry, you can submit via claims, and there's an attestation option. There are a couple of unique options for groups, like the CMS web interface is an option for groups only, not individuals, as is the CAHPS for MIPS survey. That's not an option for groups. Otherwise, for the various performance categories, qualified clinical data registries, qualified registries, the electronic medical record, and claims submission, in addition to attestation, are all options. Now I'm going to dive into a little bit of the scoring. So I mentioned these various performance categories. The category with the largest score for the first, or largest contribution to the composite performance score for the first year is the quality performance category that has a 60% score. Again, these particular measures, over 270, are all listed and available for review on the QPP website. Take home here is that clinicians are asked to submit 6 measures, one of which ought to be an outcome measure or a higher priority measure, and we've created a substantial list of measures that qualify as high priority measures. So we're hopeful that most clinicians in a broad array of specialties will be able to choose either an outcome measure or a high priority measure. Again, touching back on the prior point, although the full participation would be the 6 measures and an outcome and high priority measure, minimum participation is just submitting 1 measure, and partial and full is somewhere in between, above that 1 measure, and as much as clinicians choose to for the first year. The cost performance category was placed at a 0% impact on the composite performance score for this transition year, which is the same as we've proposed in the NPR for the second year. This category, just for completeness, is something that doesn't require any submission from the clinicians, but rather is calculated by CMS based on claims data. But for year 1 and proposed for year 2, the cost performance category will be 0%. Its contribution was shifted to the quality category that we just discussed. Improvement activities is a new performance category that's unique from the 3 prior programs that I mentioned before: physician quality reporting system, electronic health record meaningful use, and the physician value-based modifier. Improvement activities is a new category that we developed to hopefully capture many practices and actions of clinicians that we didn't think were sufficiently paid for through the existing fee-for-service model, and we wanted to find ways for clinicians to claim credit for care coordination, communication, shared decision-making, improving their clinical practice, all these activities which we think that clinicians do on a regular basis, but don't necessarily have a means of identifying in measurement. Hopefully, we think clinicians will identify lots of activities that they already do and identify new activities that can expand their practice to improve the care for beneficiaries. And this will contribute roughly 15% to the composite performance score. For improvement activities, as mentioned before, we've also developed policy that is sensitive to small practices and acknowledges the benefit of participating in patient-centered medical homes. So if you're in a patient-centered medical home or an APM designated as a medical home, you'll receive full credit for the improvement activities because participation in those entities has built in many of those items listed in improvement activities. And if you are in a group of 15 or fewer participants, or you work in a health shortage area or a rural area, you'll be able to receive full score in the improvement activity performance category by submitting half of the requirements for clinicians who are not in rural or health professional shortage areas. Now on slide 17, again, just restating that clinicians can choose to submit a minimum or participate partial or fully in the MIPS program, and we're anticipating there'll be few physicians who choose the minimal route. Slide 18 discusses the advancing care information performance category that's built on infrastructure from the previous electronic health record meaningful use program. It's important to note here in slide 19 that there are two different EHR editions and that the MIPS rule offers clinicians the opportunity to be successful in reporting regardless of whether they have the 2014 or 2015 certified EHR technology. There is an option for minimal reporting or partial and full reporting. The advancing care information performance category is unique in that minimal reporting requires submitting all of the base components of the advancing care information base score, and that is 4 or 5 measures, most by attestation, that need to be submitted to get that minimum pass. But again, based on clinicians' experience with the existing EHR meaningful use program, we think it's likely that many clinicians will submit more measures than the base measures. Slide 21 describes that we were very cognizant of the importance of providing flexibility for clinicians in reporting, and that we've included options for clinicians to choose which ACI measure make most sense to them as we move on with the quality payment program. Slide 22 is just reviewing how we come up with the final composite performance score. As mentioned in the previous slides, the quality performance category makes up 60%. Cost was zeroed out, and its weight was shifted to the quality performance category. Improvement activities accounts for 15%, and the advancing care information category accounts for 25% of the composite performance score. And what do we do with this weighting? We're going to come up with a final score for each MIPS eligible clinician, and based on the number of points they achieve, they'll either get a positive payment adjustment or a negative payment adjustment. You'll see here that only clinicians who receive 0 points will get a negative payment adjustment, which by statute is -4% for the first payment year in 2019. I'd like to emphasize that using the pick your pace model, since the only requirement is a single quality measure, a single improvement activity, or submitting the base requirements for the Advancing Care Information Performance category, it is only a very small number of clinicians who affirmatively choose not to submit this minimal requirement. Those clinicians would be the ones who are subject to the maximum -4% payment penalty. And we expect that number to be small since we've really tried to facilitate successful submission. And this just reviews again what I discussed earlier, in that for each of the categories, and particularly improvement activities and the Advancing Care Information Performance category, we've tried to create policies that minimize the burden for small rural practices and clinicians and health service shortage areas. And we think clinicians in those areas will be responsive to those changes. Slide 25, we'll be talking about alternative payment models, and I think Ben will be jumping back in now to discuss these slides.
Great, and thank you, Dr. Tefera. So as a refresher, moving on to the advanced alternative payment model portion of the quality payment program, so switching tracks here. An alternative payment model is an approach that provides added incentives to clinicians to provide high quality and cost-efficient care. So APMs can apply to a specific clinical condition, a care episode, or a population. And just to be clear here, advanced APMs are a subset of APMs, alternative payment models, and both APMs and advanced APMs apply to Medicare only. Again, as a reminder, we finalized last year that to be an advanced APM, a model must meet the following three criteria. One, they must require participants to use certified electronic health record technology. They must provide that payment for covered professional services is based on quality measures comparable to those used in the MIPS quality performance category. And lastly, they're either a medical home model expanded under CMS Innovation Center authority. And I'll note to date that no such model has been expanded using that authority, or alternatively, they must require participants to bear more than a nominal amount of financial risk. And generally speaking, we refer to these as the advanced APM criteria. In order to qualify for a 5% APM incentive payment, model participants must receive a certain percentage of payments for covered professional services or see a certain percentage of patients through an advanced APM during the associated performance year. So for performance year 2017, the percentage of payments is 25% of payments through an advanced APM, and the patient count is 20% of patients seen through an advanced APM. And just to be clear that we do the QP determinations under the Medicare option at the APM entity level, so at the participant level within a given advanced alternative payment model. We'd also like to point out here that that services delivered at critical access hospitals and other places may be counted towards a qualifying APM participant determination, and this is in an effort to include small and rural practices in advanced APMs. So this is to spotlight some advanced APMs that consider small, underserved, and rural clinicians. So here we're pointing out or highlighting the next generation ACO model, the Medicare ACO Track 1 Plus model, which starts in performance year 2018, and the Comprehensive Primary Care Plus model. These models have different components that benefit small, underserved, and rural clinicians. For example, in the next generation ACO model, there's waivers to expand telehealth and post-discharge home visits, and they do have a waiver of the 3-day SNF admission rule, and those are available to participants in next generation ACOs. The Comprehensive Primary Care Plus model has performance-based incentive payments as a part of that advanced APM, and there's also 2 tracks to accommodate a diversity of practices, and there's different risk parameters in those tracks. And so there's a number of things that we do for small and underserved and rural clinicians in these advanced APMs, and we just wanted to highlight it. And if anybody wants more information on these particular advanced APMs, they can visit the CMS Innovation Center website, where we have specific web pages for each alternative payment model that we operate. And so this slide details the Physician-Focused Payment Model Technical Advisory Committee, which was created as part of the Quality Payment Program, and we finalized in last year's regulation. A physician-focused payment model. And this process is stakeholders can submit a model proposal to the PTAC, which we're calling the PTAC, the Physician-Focused Payment Model Technical Advisory Committee, which is made up of 11 appointed care delivery experts. And they review the proposals and then submit recommendations to the HHS Secretary. The Secretary, a combination of the Secretary and CMS, will comment on those proposals. And then ones that are recommended to be implemented are then come back to CMS and are implemented by the Innovation Center. I will say to date, we've gotten a number of letters of intent for proposals to be submitted by different stakeholder groups, and there have been a number of proposals that have been submitted as well. And now I will turn the presentation back over to Dr. Tafaro to talk a little bit about technical assistance for clinicians, and then to go into some of the changes in the MIPS program for the year 2.
Thanks, Ben. Looking at slide 29, what this overview slide really is trying to communicate is that we've spent a lot of energy trying to address the various needs of clinicians in rural and health service shortage areas, and have tried to stand up as many opportunities to assist these clinicians be successful in the quality payment program, be successful in having electronic health records, be successful in not only gaining experience with performance metrics, but also the submission process. And I'll go over a few more examples over the next couple of slides. But again, the take-home is that there are a lot of opportunities available for clinicians who feel like they need help to affirmatively seek help and get direct assistance from CMS. One of these examples is the Transforming Clinical Practice Initiative for Rural and Underserved Locations. TCPI has over 100,000 clinicians and over 20,000 practice sites. There are regional transformation networks across the country that are focused on managing particular bundles of these practices, and they're charged to help these clinicians improve not only their overall care delivery, but also offer assistance, especially to those clinicians who are committed to working in rural health clinics, rural community health centers, professional shortage areas, and underserved populations. The legislation directed CMS to focus on this issue. There was a specific amount of appropriation per year to support technical assistance, and the cutoffs for technical assistance, the cutoff of practices at 15 or fewer clinicians, for example, was explicitly written into the legislation by statute to give the agency direction on how to help clinicians in these identified areas be successful. Again, the clinicians who are working in rural and other health service shortage areas are really encouraged to use the existing web portal resources to identify their needs and to help the agency connect them with the resources we've stood up to help address whatever assistance that they think they need to be successful. The quality improvement networks and quality improvement organizations, looking at slide 32, have various opportunities, and the information to contact them is listed here. But in addition to the QIN and QIO network, there have been 11 organizations that have been charged throughout the country, and this slide here shows the geographic range of these 11 organizations that are responsible for caring for the needs of clinicians caring for patients in underserved and rural populations. Clinicians are encouraged to contact these organizations, and those organizations are charged by the agency and responsible to addressing the specific needs addressed or brought up by the practice. Again, the idea here is that each individual practice will have unique concerns, and we want to make sure that there is an agile process that's regionally based and understands the concerns of clinicians in specific parts of the United States to try to help them become more successful. One method that we concluded would be helpful for clinicians to be successful in the MIPS program is making sure that we had exclusion thresholds that helped us focus really on the vast majority of Medicare Part B spending. So for clinicians who fall below the low volume thresholds of $30,000 or see fewer than 100 Medicare beneficiaries, we determined that it was not in the interests of the program and the intent of the statute to have these low volume clinicians participate. And as I mentioned before, for clinicians in rural health service shortage areas, the clinicians caring for underserved communities who do participate, we've tried to decrease the challenge of the performance categories by having unique modifications, including decreasing the requirement for the improvement activities and making sure that clinicians working to promote access for Medicare and Medicaid beneficiaries get credit for their work in critical access hospitals, rural health clinics, and federally health qualified centers, including using that participation to eventually be a successful participant and a qualifying participant in an advanced alternative payment program. This is a good transition to the work we're continuing to do to improve the quality payment program. To review the proposals for changes that we're seeking comment on. The proposed rule for year 2 was released just last month, and although I've mentioned clinicians that have fewer than $30,000 of Part B charges or see fewer than 100 beneficiaries are excluded, we are seeking comment on having a broader range of exclusions. So we would increase the monetary exclusion to $90,000 and increase the number of beneficiaries seen to 200. So if you had charges less than $90,000 or you saw fewer than 100 beneficiaries, you would be excluded from the MIPS program. There's also language in the proposed Year 2 rule that describes virtual groups. Virtual groups was described and called out in the original statute, but we did not propose rulemaking language in the first year so that we could focus on getting the details of the 4 performance categories flushed out as best we could. So in year 2, there's language describing the process for participating in a virtual group. And the salient point here is that it mimics most rules for group reporting. So if you feel like you have a general understanding of group participation and group reporting in the MIPS program, then you generally have an understanding of how you could be a successful virtual group participant. There's also further language in the proposed rule about facility-based measurement, and this was designed to address concerns of clinicians like emergency physicians and hospitalists whose primary clinical time is associated with a facility on how to help them be successful. And further language on the quality performance category and the cost performance category. as I mentioned before, cost will continue to be weighted at 0 for year 2. For improvement activity, we continue to seek suggestions for developing new improvement activities, and we expanded the number of improvement activities from roughly 92 to around 120 for year 2, and we're hopeful that the clinician community will identify even more activities that they think contribute to their practice and improve beneficiary care. There are also proposals for how best to calculate the medical severity, the medical illness severity of patients in our scoring calculation, and we see comment regarding that. Further language about are there more ways to support rural practices by giving them financial incentive, and there'll be opportunities to hear feedback from our stakeholders on that issue. And regarding choosing a performance threshold, what is the best performance threshold to identify for minimum performance, and how can we change that performance threshold to spur ongoing improvement without diminishing the opportunity or availability of success for clinicians in the quality payment program. The next slide just goes over again the difference from $30,000 to $90,000 for the exclusion, and from seeing fewer than 100 beneficiaries to seeing fewer for 200 beneficiaries for year 2. Earlier in the slide presentation, we talked about who participates in MIPS. It's important and I think easiest to think of all clinicians who are physicians, physician assistants, NPs, clinical nurse specialists, and nurse anesthetists. All these clinicians will continue to participate in MIPS. We will not be changing that for the second year. It's something that we'll address in future years about including other clinician specialists in the MIPS program. One thing to note there is that even if other clinicians are not necessarily called out to participate in MIPS, they can still participate in alternative payment programs. They just won't necessarily receive any of the financial rewards from the program. But as far as quality improvement, if they have a desire to participate, there's no exclusion for participating. There's just not a link to a payment bonus. For virtual groups, again, I think the easiest way to think about the proposed language for virtual groups in the NPRM proposed rule for the MIPS program is that it mimics rules for groups in the MIPS program. So if you think you understand how group practice reporting works, then it's likely that you'll do very well understanding how the virtual group practice works. Again, this will be the first year that we're proposing it, so if there are alterations or edits to our proposals that you think can help it make it more efficient, we're happy to receive comments on that. And this slide here just kind of expands on the fact that it's still a work in progress. Non-patient facing clinicians, this is an issue we spent a great deal of time on in the first proposed rule that was finalized last fall. It's important that we continue to refine how we're defining these clinicians. Currently, it's clinicians seeing less than 100 patient-facing encounters, and in groups, the national provider identification numbers for each clinician, that greater than 75% of the clinicians in that group meet this non-patient-facing category. And again, like I said just a few slides ago, that will be the same standard for virtual groups. And for those that are not aware of how we come up with these determinations on how many patient-facing encounters a clinician has, that's actually relatively straightforward using claims data that we receive based on what clinicians submit. For the second year, it's important to note that the initial Pick Your Pace program will not continue, and that clinicians are expected to submit more than a single measure of activity. But again, we do think that even during this first year of MIPS that most clinicians will submit more than a single measure activity anyway, and that will be the expectation for year 2 moving forward. Regarding the scoring for the composite performance score, again, this is related to the expectation that more clinicians will be submitting more measures and activities, either partial or full year submissions as previously described, and the absence of the Pick Your Pace option has prompted us to change the minimum threshold for points from 3 points to 15 points. But again, based on prior clinicians' experience in the physician quality reporting system and value-based modifier and EHR meaningful use, we think even in this year there will be a great deal of full participation and expect that to continue moving forward. The statute calls out for increases in the payment adjustment, the bonus or the penalty from year to year. So for the first year in 2019, it's -4% to +4%, and it can be higher depending on the circumstances. For the second year, it's -5 or +5%. And again, this is all detailed in the MACRA original legislation. Going over the performance threshold and scoring again, you'll see here these are just small tweaks to acknowledge that there'll be more clinicians submitting more measures, that scores are expected to be higher, and that to avoid a negative payment adjustment, it's really important to participate and to submit. And again, we don't expect many clinicians to result or find themselves in the category of having 0 points and receive a full -5% negative payment adjustment, because those physicians and clinicians will be able to submit either improvement activities or quality measures or EHR advancing care information components that will lift them above 0 points to bring them somewhere above 3 and less than 69, so they'll avoid a negative payment adjustment. This slide here reviews submission options again. All the same options are available: claims, qualified clinical data registries, qualified registries, attestation, and for groups, the web interface will continue to be an option. Facility-based measurement, as I mentioned earlier, is something that we're seeking comment on for year 2, and this is just acknowledging that there are certain clinician types that spend most of their practice within facilities, and is there a way to measure their contribution to patient care, the quality of their care, using other existing measurement frameworks that we have in our hospital-based programs. So we're seeking comment on whether this is a viable option, and certainly those specialists who are hospital-based or facility-based, we look forward to hearing their feedback on whether this is something those clinicians will find helpful.
And great. Switching gears and moving back over to discuss advanced APMs and changes that we are making to the advanced APM portion of the quality payment program in the proposed rule for year 2. I'm going to drill down here into the generally applicable nominal amount standard, and this is part of the financial risk criteria that I mentioned before. And the financial risk criterion is one of the 3 criterion to be an advanced APM. And part of that criterion is, in last year's final rule, we updated a nominal amount standard requirement for advanced APMs so that it could be defined in either total expected expenditures or total participating or total revenue. Specifically, we finalized that total potential risk under the APM must be equal to at least 3% of the expected expenditures an APM entity is responsible for, and we finalized that for all performance years, or 8% of the average estimated Parts A and B revenue of the participating APM entities, which was only finalized for the 2017 and 2018 performance periods. This year, we are proposing to extend the 8% revenue-based standard for an additional 2 years through performance period 2020. And I should note here that this proposed change would only apply to the Medicare ACO Track 1 Plus model, because at this time, that's the only model that is utilizing the revenue-based nominal amount standard. Moving on to slide 51. Last year, we also finalized a definition of a medical home model, and in the MACRA statute, they defined what a medical home model was, which was different than a patient-centered medical home model. And we also, in last year's final rule, put forth different financial risk and nominal amount standards specific to medical home models. And so in the next couple of slides, I'll discuss some changes we're making here in the year 2 proposed rule for specific to medical home models. It was finalized in last year's rule that starting in performance year 2018 and later, the medical home model financial risk standard would only apply to APM entities with fewer than 50 eligible clinicians in their parent organization. We are proposing to maintain this standard with a limited exception this year. Specifically, we're proposing to exempt round 1 or current participants in the Comprehensive Primary Care Plus model from the requirement that the medical model financial risk standard only applies to APM entities with fewer than 50 eligible clinicians in their parent organization. However, all future participants in CPC Plus and participants in any future medical home models will be subject to this 50 clinician cap. We're also proposing one additional change to the medical home model nominal amount standard. In last year's rule, we finalized that the total potential risk for an APM entity must be equal to at least 2.5% in 2018, which would gradually ramp up to 5% in 2020 and thereafter. We're proposing to change this standard for medical home models so that the minimum required amount of total risk increases more gradually, starting at 2% in 2018 and ramping up to 5% in 2020 and thereafter. We believe this approach may allow for greater flexibility and encourage more participation in medical home models and be more sustainable for the types of APM entities that would potentially participate in medical home models. This slide talks about the all-payer combination option, which begins in 2019. And the all-payer combination option allows clinicians to claim credit for participation in other payer advanced APMs, that is advanced APMs with non-Medicare payers, and that option begins in the 2019 performance year. We've made a number of proposed changes to the all-payer combination option and QP determinations under the all-payer combination option, but we're not going to discuss them in detail at this presentation. We do have more information on all the changes that we've made there, and as well as the determination process for other payer advanced APMs. And we have a fact sheet and then also a recording of recent webinars we've done that go into detail about that part of the advanced APM track. So now I'll turn it back over to Colby to go over comments, and then we'll move into the question and answer session.
Thank you both. That was quite a lot of information. One quick note for everyone who is attending that we will be making the slide deck and materials available to you after the session, so don't worry if some of that flew by. And as well, we do have quite a few questions that did come in via Q&A, so if it's all right, I think we'll dive in to that Q&A section. Just as a reminder, if you are watching WebEx in windowed mode, on the right side there's a Q&A box where you can type in your question and hit send, and if you don't see it, click the Q&A icon in the top right to make it appear. Similarly, if you are in full screen mode, there's a Q&A button within the controls at the top of your screen. The first question, we are a small clinic with one participant, and we have 2 TINs associated to the NPI. One TIN is for the clinic and one for hospital patients, and we as clinic staff only have access to clinic patient records. How do we report for the second TIN that's being used to bill for the hospital patients?
Hi, this is Lamanna Tefera. Good question. I think it seems like you have an understanding of what to do for your typical group. The specific reporting method may depend on which TIN NPI combo you're using for the hospital-based patients. Because there might be some details here that are not phone or quick answer friendly, I would offer that you can send your question to the web team here, and I can connect you with our MIPS group reporting team who can give you a more detailed response and make sure you navigate the reporting successfully.
Question number 2. I'm a single practitioner with no EHR. My practice consists of only interpreting echocardiograms without any face-to-face patient contact. I do bill Medicare for more than $30,000. How do I participate and how do I submit?
Hi, this is Lamanna Tefera again. I think the first step to determine whether you are required to participate would be using your National Provider Identification Number, going to the Quality Payment Program webpage, which is qqualitypaymentprogram.cms.gov. And on the far right of that page, there is an NPI lookup tool. So I would see that what we've determined so far whether you are eligible or required to participate or not, and then move from there.
Excellent. Another good question came in here. With the increase in threshold for the eligible clinicians, what is the estimate of how many total clinicians will be excluded?
Yeah, this is Lamanna Tefera. So for the first year, I think we had a roughly 1.2 million potentially eligible clinicians. After modeling based on the less than 30,000 and less than 100 beneficiaries, I think we predicted around 550, 600,000 clinicians would participate. So for for a considerable expansion of the exclusions, that number will decrease. I can't tell you decrease to say it would be less than 550. I don't have an exact number to tell you, but I think the interesting policy challenge for us is, are we including the clinicians who have a significant contribution to Part B services? So if we're excluding clinicians that actually don't participate in Medicare so much and don't charge Medicare so much, and we're still retaining the majority of clinicians who are high utilizers of Medicare and high billers of Medicare, is it possible to continue to be successful? And that's certainly the aim.
This one came up twice in a couple of different formations. I'll try to read the most concise one here. If a currently exempted clinician, for example, a very small practice, submits all the items required of eligible providers, regardless of the fact that they meet the monetary or beneficiary threshold, that they're below the threshold, will they be able to obtain the financial incentives because they're participating now?
Yeah, this is Lamanna Tefera. So the answer to that is no. Although we encourage clinicians to voluntarily submit even if they have a reason to be excluded from the MIPS program, in the current rulemaking, that's not an option. There is future language about opting in. This is something that's been proposed for comment, especially with the expansion of the exclusion criteria from less than 30,000 to less than 90,000 and less than 100 to less than 200. there may be clinicians who feel that they are strong in their quality performance and want to receive credit for that because they've dedicated time and resources not only to the measurement but just to improving their practice. So we've sought comment on an opt-in option for clinicians who are excluded but want to participate. But in this current year, that is not the case.
Very good. Another with a bit of specificity here. Please clarify the inclusion requirements for facility-based clinicians. If a provider is primary hospital inpatient-based and bills Medicare Part B under their own NPI, are they considered an EC that needs to participate in MIPS?
So this is Lamanna Tefera again. So again, for participating in MIPS, the assumption should be that you're participating in MIPS unless you have one of the exclusions mentioned regarding the low volume thresholds or a new provider to Medicare. Regarding the proposed changes for facility-based providers, that is in the current proposed rule for year 2, and that is open to comment. There's no final rule or determination regarding that, and we're happy to receive feedback. I'd encourage you to review the much more detailed explanation of facility-based participation and see if your practice colleagues think that our suggestions are reasonable or have ideas of how to improve what's in the proposed rule.
In the interest of time, we're going to do one more question here before moving on. Rest assured, there are still a number of questions here that have been asked that will be forwarded along both to our speakers or to a Care 360 representative as necessary. The final question for today, we are a small to medium-sized office with no EHR. What is the easiest mode of reporting for MIPS for them?
Hi, this is Lamanna Tefera. So, for example, if you don't have an EHR, there's language in the existing rule to seek an exemption from the advanced care information performance category regarding submitting claims. If you're not using an EHR, there are options to submit claims-based quality measures, and that's always been the case. And that would be just flagging your claims independently for those that you want to be considered for specific quality measures that you think make sense for your practice. And for improvement activities, once you have your quality payment program access established, that is an attestation-only submission. So you'd go onto your secure portal and attest to completing the improvement activities that you feel you've done in your practice, and that would be sufficient to meet the requirement for the improvement activities. So the take-home message is, even if you don't have an electronic health record in your office, you can still be successful in the quality payment program in MIPS by either using claims-based quality measures, seeking exemptions from the advancing care information category, and submitting online for the improvement activities category.
Thanks again, Tef. And thanks to both Ben and Tef for their expertise and their attendance here today and helping us out at moving forward and trying to understand some of the changes that are coming to the QPP, certainly in year 2 here.
We'll now turn our attention to our sponsor, Care 360. Care 360 offers a complete end-to-end solution for all of your practice needs. We focus on the business side of things so that you can focus on your patients. We connect healthcare organizations, community physicians, and patients to improve access to information and insights. Our applications work harmoniously to promote physician loyalty, provider collaboration, and positive patient outcomes. Because we're backed by Quest Diagnostics, you know that you can rely on a stable and proven partner. Our network is strong, connecting over 450,000 physicians and touching the lives of over a third of all Americans every year. That confidence and reliability that comes standard with every Quest Diagnostics Care360 relationship is easy to appreciate and to benefit from. Our holistic suite covers every aspect of your patient and practice lifecycle, from appointments and reminders, documenting a patient visit, verifying insurance, processing payments, and right through integrated follow-ups via our MyQuest patient portal. If you're looking for a complete solution from a single source, Care360 has you covered. Our electronic health record is an ONC certified, award-winning product that works extremely well with small practices like yours. It's cloud-based with powerful mobile integration to your smartphone or iPad, allowing you to work wherever and whenever it's convenient for you. The practice management side allows your front office to work more efficiently to manage the flow of patients, keeping your practice organized and agile, linking directly to your EHR so that you can spend more time focusing on your patient and billable encounters instead of the front office administration. And if you're considering an enhanced medical billing service, Care360 has an outstanding revenue cycle management product as well. Few things are as time-consuming for your practice as billing and collections, so handing off the more monotonous busy work can free your staff to focus on patients instead of spreadsheets. Trust Care360 to provide you with a solution that's up to date on the evolving trends and changes in the industry. If you have more questions about Care360, please feel free to call or email using the contact information on the screen. And once again, we thank you all for your attendance today.
And a special thanks to both Tef and Ben from CMS, and of course Care360 for sponsoring the event. Keep an eye on your email inbox for additional seminars covering related issues in the near future, and thank you all once again. This will conclude today's presentation.